Good afternoon, and thank you for being with us this afternoon. So I invite our panelists. As Lynn said, we have two patients and health professional. Okay. Ah, d'accord. Okay. Health professional from different disciplines. So maybe please have a seat, and thank you to all of you. I mean, maybe I can sit there, and maybe Klára and Heike. Our two patients. Klára is patient type 1 diabetes, and Heike is type 2 diabetes. And thank you again. We greatly appreciate having you on board. And please, so Agata, who is a psychologist, and Jean-Philippe, who is clinician. Okay. Je sais pas. Si. Ah d'accord. Ok. Et ça je mets. Bon. Sorry. And Augustin, who is a nurse from Netherlands, and okay. Yes, please, Kamlesh. Sorry. Ouais, voilà. C'est où mes papiers? Bon, ok. Oui, merci. Merci, sorry. Well, it's a great pleasure for me to facilitate this roundtable discussion. First of all, because it's a key issue, as we've seen with Professor Rieit, with his excellent presentation. And I'm sure that all of you, you will have questions and comments to make, I'm sure, because we already started the discussion about clinical inertia, and we know that, as you said, it's a complex issue. So, and also, thank you very much. We would like this roundtable be focused on patients. So that means it should be a very practical discussion. Why on patients? Because as a complement to, to our previous presentation, and also, to really focus on how the patients are living with the disease every day, what challenges they are facing, what are their expectations, and what are maybe their recommendations. So this is what our roundtable is about, with one objective maybe would be to try to find out some ways of improvement, some room for improvement, maybe some innovative approach and new opportunities for collaboration, and maybe new areas for further research. And I think that we already started the discussion. So why don't we ask our panelists, maybe each of them, to share with us their own experience, in relation with the issue of non-adherence, and given their own setting, how do they see, this issue, and also, of course, if they can introduce themselves, and again, as I said, maybe share with us their comments, and if they have any maybe focus they would like to draw our attention from the presentation from the Professor Rieit. So who would like maybe Klára, you would like to start? Thank you.
Okay. So my name is Klára. I'm a doctor, journalist, and a person with type 1 diabetes. And listening to the previous talks, I just want to make a few comments. First of all, we're talking about adherence and non-adherence, but adherence to what? From a clinician's perspective, it's adherence to treatment, but from a perspective of a person with type 1 diabetes, it's the other way around, because for a person with type 1 diabetes, life comes first and diabetes comes second at the best. So a clinician may want a patient to adhere to treatment, but a person with diabetes may want diabetes to adhere to their life. So these 2 points of view might not meet themselves in the clinician's office during an outpatient visit, and that makes the goals of the person with diabetes and of the doctor different. Actually, the best diabetologists or diabetes specialists I know are those who either have type 1 diabetes themselves or those who have the biggest insight. They don't need to have the disease, but they have insight from diabetes camps, from sports activities. They just know how it is to live with diabetes, not only in the office in the 15 minutes, but in the real life as well. And it's a big difference, because if you take a physician to mountains with patients and you ask them to control the diabetes in real life, they often don't know what to do, and because it's a different life. And so I think having an insight to everyday life is a big help in sharing the treatment plan or the management plan, because in type 1 diabetes is not really treatment. You cannot make it better. It can only get worse. So it's more of a management. And from my point of view, it's really important to have the technology to do it, to have the education, and to have the emotional support, which comes from the healthcare professionals, all the 3 parts, to the person with type 1 diabetes. And yeah, that's probably it.
Well, thank you very much, Klára. As you can see, Klára has a lot to share. Maybe, Agata, what do you think about what she just mentioned about the difference in views as patients, as clinicians?
Thank you. And what Klára said, I found very important, because first is life and second is diabetes. And sometimes I think that it's very easy to forget that patients also have some other stressful life events. And I think it's a great challenge, to cope with stress, to overcome life obstacles, to achieve some personal goals, and to maintain diabetes self-management at the same time. And I think that's, as we heard in a lecture, it should be individualized. And first, we have to recognize the patient individual pyramid of life values, because for example, for some people it can be family, health, but for others it can be work, studying, sport challenge, or for example pleasure. And it's very important to find the connection between the most important thing and treating diabetes or diabetic goals. And I found very important thing in a lecture, that all of us want to have immediate effect. And in diabetes it's very hard, because there are no visible effects. It's very hard to see in diabetes, and I think that it's very important to realize that there are some good effects, and we are responsible also for the process, because a doctor, a nurse, psychologist, dietitian, educator, and other professionals are responsible for the process of treatment, for information we give to patient, for questions we ask. But patient plays a vital role in a final effect, because I think that the patient decides how he or she is going to use it, this information, and what is he going to use it, what's his idea on this treatment.
So is your role as a psychologist, to help the patients better understand what is at stake?
I try to figure out with patient what's also individual goal for this patient. Is diabetes is a good treatment needed to, for example, have some sports challenges, or maybe it has to be a goal for his education, studying, because I try to figure out what's the most important thing in this patient life, because if there is very important thing, we can connect it with diabetes treatment and some goals.
Yes. Thank you, Agata. Maybe Heike, what do you think about what just Agata said? Because is there any particular moment in your life when it has been more challenging, to adhere to your treatment? And what support, did you get at that time? Or what support would you have expected? And yes, and of course, and also, if is there any, on the other way around, is there any moment where it has been much easier to adhere to your treatment? And is it an issue about motivation or, yes, if you could tell us.
Okay, that's a lot of questions, I think. I start with the beginning. I was diagnosed with diabetes type 2 when I was 36 years old. It was a shock, and it was the worst thing that happened to me. And on the other hand, it was the best thing that happened to me, because I was, I had a lot of fatigue before. I had a lot of weight gain. I couldn't be active. But this started when I was 18 years old, and I couldn't be active anymore. Like, I did a lot of sports before, and then I started to gain weight. So I wasn't that active anymore. So I gained more weight, and it was like a vicious circle. And this is before I was diagnosed. I was kind of really afraid to get the diagnosis, because it was plain that there's something really wrong with me. And then I had it by chance. I had my septum, a correction of the nose, the septum, and they started measuring the blood sugar levels for the operation. And I was 3 days in hospital, and they checked them, and they said, okay, there's something really wrong. You should get this checked. So I got home, and for 3 weeks I did not want to have it checked. And I had really, really bad weekends, because I was always functioning really efficiently during my studies or my work life during the week. But on the weekends I had breakdowns all the time. And it was affecting my marriage, it was affecting my friendships. It was really bad. And then I went to the doctor, and then I got the diagnosis. And the nurse actually asked me, so, would you like to be able to see, and would you like to be able to walk in the coming years? Which is kind of like a what? I started to cry, and then I said, okay, we have to do something. And from this day on, I started with, I had 9.9 HIC, A1C, yeah, whatever. And so I started my injections right away. And in 3 months, I went down to 6.1. And I had this schedule to live by. I was looking for what do I eat, when, how do I do it. It all came very naturally, and I really loved the specifics I had to follow. And this came very easily to me. And then, but it took a long time before I really lost weight. And I think this was the critical thing that really happened. I wanted to have a baby. And after 4 years, I lost 22 kilograms of weight, and could stop using insulin. And this is when it happened. And then there was the pregnancy. We had a very strict monitoring with a lot of doctors, like my gynecologist and my diabetes center, and they all worked very closely with me on this. And it was a very healthy pregnancy, and I did a lot of sports during it, and I had a healthy baby. And this was the time it was really, really going very well, because I could cling to a strict plan, which was easy to follow. This was the motivation for me, not only the baby, but when I can really work around some schedule, it's really easy for me to follow. And at the moment, my mother-in-law is very sick, and we had to do a lot of adjustments with childcare, so I'm under a lot of stress. And at the moment, I'm gaining weight. Even so, I don't eat more, but I just don't have the time to exercise, and I have a lot of stress. So I'm in a circle at the moment. I just think, oh God, I don't know really what to do. So at the moment, it's really hard for me.
And you think you had, you were educated enough? Or were expecting more.
Sometimes it's so hard to
Yeah.
know what questions to ask because you don't know what possibilities there would be. So people are there and you could ask them, but you just don't know because you're not a medical trained person. You're just a patient.
But your experience shows the importance of the motivation. I mean, because
I
the
think
baby
this
was
is
a
the core.
good, the baby was good. And also from your experience, I think maybe do you think that we should focus more on education, but focusing more on people at risk?
Yes, definitely. Definitely, because I think you have to, you can actually, there's so many signs for pre-diabetes or anything, you can really get it before it gets too late.
So thank you very much. We will come back to you. Kamlesh, maybe you'd like to also to develop the issue about education, because as a primary care expert, you are at the forefront.
Okay, so in my opinion, I think we pay a lip service to education. We're very passionate in our research program in terms of education, but education seems to be the last thing on the minds of payers and healthcare professionals as well. We dish out tablets quite easily to patients, and as you know, the adherence rates are very low, 50% at 2 to 3 years. But we know that the education programs will improve adherence rates. If I were to tell you that at the moment we have tablets, we have injections, new injections where they cost £90, which is something like 120 euros per month. And they reduce HbA1c down by 1%. Some of the GLP-1 injectables. If I told you I had a tablet which brought HbA1c down by 0.5%, it increased physical activity, reduced smoking rates, made the patient feel better in terms of their quality of life, depression levels went down, and the patient felt that they were more in control of their diabetes. If we had a tablet like that, how much would we pay for that? And that's what we have in terms of education programs. This is from randomized control trials we've done with Desmond and others have done. All of those outcomes are improved. And the cost of that is £80 per year. We just don't seem to be paying for that. We say we will give education. Everyone has education. But there is the type of education is important as well. And again, the analogy there is you wouldn't just buy a metformin from over the counter where it's not been tested. You want to make sure that metformin has been rigorously tested in a randomized control trial, and it's shown, and it's quality assured. While for education, we'll say, well, any type of education will do. We won't go for an education program that's randomized control trial, that's shown the evidence base, and it's quality assured. So if someone in France gets it, it's exactly the same as what you would get in Scotland or England. That's what we get with metformin. We don't get that with education. It's not a quality assured program that people will get. And the education programs are variable. Some of them may do harm, but they've never been tested out. So I think if we really want to emphasize education, we need to get into a space where everyone buys into it. We give it as much importance to education as we do to medications as well. Only then will we get education in clinical practice for every patient. And it's just like tablets. You don't just take it and then stop the tablets. You keep taking the tablets. Education is exactly the same way. It's not a one-off. It's a continuous educational program.
So, in other words, you think that we should initiate further research on education?
Well, there is research evidence is already there. There's a number of good randomized control trials. There's meta-analysis of randomized control trials of education programs. We know the components of those programs that work. So the evidence base is there. What we need to do is get those programs implemented.
But thank you very much, Kamlesh. But Augusta, you are involved in such an education program using new technology and phone call and coaching. So what is, how do you see this education, evolve with
Yes, well, actually, I'm not involved in an educational program. I am a nurse. I am a diabetes nurse from the Netherlands, and I stepped out my profession of regularly diabetes nursing because education had not the position in the structure in primary care as it deserves, as is needed. So I was diabetes nurse for several years, for 15 years, and then for 9 years, and then I decided to step out and start an own practice. I not stepped out definitely because I still had to earn my how to say to have a profession and a job, but I tried to add the other approach so people could come to me when there are questions. And in fact, the term non-adherence is blaming the patients where there is a lack in education. And coaching is actually, or the way I started working, is actually solving the gap between instruction, information, and education. Education is bilateral, and instruction and information is actually one way. So there where the patient has his questions or her questions and the lifeline, and at the one moment you have not a question, people don't report hypoglycemia. They report, I cannot sleep, I lay awake, I'm hungry, but I have to test my fasting blood glucose. Or they have high fasting blood glucose, but the doctor or the nurse never asks, are you hungry in night? So the information of the fasting blood glucose might be wrong. Maybe people get higher doses and doses medicaments, drugs, because they don't ask the right question. Are you hungry in nights? And is your fasting blood glucose really fasting? So I had another approach, and I called myself diabetes coach, and I studied coaching. And meantime, 20 persons in the Netherlands call themselves diabetes coach. From where there are 11 who have type 1 themselves. There is a psychologist who has type 1. There is a nurse who has type 1 who calls herself diabetes coach. And there is a nurse who has type 2 who calls herself diabetes coach, but it's in my presentation. But it's not reimbursed. Only in 2 cases it is reimbursed by a woman who is mother of a child with diabetes. And she gets her coaching practice because she is a coach as professional. She gets it reimbursed by the insurance, therefore. But it's not a diabetes education program. It's the first, as you said, which is skipped from the whole treatment. But there is a guide for patients with chronic diseases to learn and to make their voice heard. And we have the IDF guidelines for education, but no one knows, and it's not really in the program of treatment.
So what would you expect, to move forward from the political side?
Well, I think what you say, Kamlesh, it's very, very important that it is seen, and I'm very happy that so many patients say, well, when you as healthcare professionals don't solve the problem, we do it ourselves. 11 of them call themselves diabetes coaches, and I think it's very important to implement education and to give it the value as it has. It is proven. Before it's getting wilder and wilder, and everybody takes the market because there is a market in it. I think the working together, the cooperation with patients themselves, because we are no opponents, patients and healthcare professionals. We have to work together, and we have to use the techniques and the social media and all the way around how to get better information, because information is slow, inert, and the access to information is not broadly. I think professionals are very skeptic about information which is not under their control. And I think the skepticism and the mandate should be discussed again.
Oh, shoot. Oh, sorry. Thank you very much, Augusta. But just a word maybe from Philippe. Do you think that education should be targeted more at specific group? For example, depending on the different period in life. For example, I want to have a baby. I'm going to leave my family. I'm going to move.
Okay. So, good afternoon. I'm an endocrinologist. I'm the clinical director of the Portuguese Diabetes Association, which is a kind of different structure also. And to try to reply to your question, because I tried to systematize a little bit of my points here also, and I think I can answer with concerning that. First of all, I think that we have to deal with education in a disease-related content. That means that we are always speaking about diabetes, and we are speaking about different diseases. Type 1 is completely different from type 2, and even if in type 2 we have different subtypes of type 2, and we try to mix all in the same package, and that gives a very confusing sign to all the populations, including the healthcare professionals. And that's also part of the responsibility of that clinical inertial, because we are mixing all the things in the same package. Second aspect that I've put it here, and even if as a healthcare providers we try to be very confident in our knowledge, in diabetes we have still a lot of unknown, and it's very difficult to accept that. And so we don't know how to stratify correctly our patient. We don't know who are the responders versus the non-responders. And even when we see that data that Gerard has shown us about adherence versus the health outcomes, of course we have seen that it seems that higher adherence levels are related to better health outcomes, lower A1C. But it's just a question of adherence, or are those people that have higher adherence, they are really different from the other ones? It's just a measure of association, or it's a cause effect, and we don't have a good answer for that, I think, we can discuss that. The other one is from the guidelines from the randomized controlled trials, and now we are trying to move from that data from the real life, from pragmatic trials, from big data analysis, from identifying patterns in the population, and that's still a process that perhaps will help us in the future, but not at the present moment. We still miss a lot of data from these big data analysis, but we should try to put some money on that, because probably some of the answers will come. And then I think, and that was a good point about the evidence-based medicine versus the emotions, and I think this group from the education, these healthcare providers that are dealing with the education, as in this group, it's always a question of, is education versus the scientific mode? And that's not at all the yes or no, the good and bad. We, as healthcare providers, we have to have a robust scientific background, and we have to deal with education, considering all the theoretical aspects that were dealt here. And again, there's that mixed feeling, and probably that's what Kamlesh was saying. People are not giving the proper value for education, because it seems that it should be in our daily life as healthcare providers. It's just a question of good sense, and that's not the point at all. We should have teams properly trained on on these aspects of education, and probably it's our fault as healthcare providers that we are not putting that on place, and we are just saying that education, everyone should have access to education. We give education, and the value is low, apparently is low, and I don't know if it's good. If we put it at a higher level, and if we provide the randomized controlled trials, probably we should have better reimbursement for education. And then there are people-related individual factors for education, and I think that's a question of motivation. That's type 1, considering all the life cycle, and when we're questioning, should we have programs for type 1 diabetes, or considering different areas on the life cycle of the people with type 1 diabetes, and for type 2, the same thing. And we are not providing that. It's just like a program for type 1 or a program for type 2 diabetes. And something worse, and perhaps I can come back later, so not to monopolize the discussion here. It's the proper concept of education that we are mixing here. I think even in Europe we are considering education a lot of different things. It's again about information, about how to give the information, but education should be much more than that. Should be an integrated part of the process of care. And I don't think, and it's kind of my group opinion, that it's not just the role of one person, it should be the role of every stakeholder involved in the process. So it's not good just to say that the physician are the prescriber and then go to the educator or go to the nurse to have education. We think that the education could start at the doctor's appointment and then continue through the nurse, through the educator, through the pharmacist, through the other healthcare providers. They should be coordinating. That means that information should flow through this circuit, and that's not happening still. And so these probably are some of the gaps I can identify in the process, and I can come back later to other points. Okay. Thank you.
Thank you, Philippe. And I think that your last point is very important, because we know that we cannot rely on the physician alone. And so maybe one question would be how to really engage a wide range of stakeholders, including civil societies, including maybe businesses. We just talk about pharmacies, and of course, why not municipalities, in order to create the enabling environment for the patients to understand, what are their own resources, maybe, and how they can find their own sense of creativity and motivation to improve their own quality of life. What do you think?
Well,
yeah?
Of course, we should involve all the stakeholders. And again, considering the scarce resources that we have, the more we allocate to this war against diabetes or trying to have better results on diabetes, of course, we should engage them all. But the problem, again, is we should engage them and put it in the right place, being part of the system, which is different that meaning that we have just different people in the process. Again, I think that's the coordination process, and who's the coordinator of this process that we should discuss. For instance, in my country, we are putting a program now for the prevention of type 2. It's a national program. We are involving municipalities, pharmacies. But there is one stakeholder, that's the diabetes prevention manager. That's the people, that's the person that's engaged for each region to put all the resources working in the same way. Otherwise, we should have people promoting physical activity, people promoting health in cooking, or in different roles in everything in 1 month and nothing happening in the rest of the year. And so that role of the coordinator should be someone very important. I don't think they should be at a healthcare center, or even if it's not necessary for this purpose of prevention of diabetes. It could not be a nurse or a doctor. It could be someone from the community. But it, again, should be properly trained on this job.
So it's always about education. So before giving the floor to the audience, because I'm sure that you will have some questions, maybe would you like to say one word about the issue of clinical inertia? Maybe Kamlesh?
Clinical inertia, we've been talking about this for 15 years. You showed some great slides. If you look at clinical inertia, it's not changed, it's got worse. So HbA1c at which people are initiated on insulin, for the past 10 years, it's been 9 or 10%. We're not getting any better. We keep talking about it, but we're not overcoming the inertia. And one of the main reasons for that is we haven't got good trials. We've got lots of observational studies that clinical inertia is prevalent from many, many countries. But we haven't got many studies which show how can you overcome inertia. So at these meetings when we come to ESD, ADA, we get a chance to meet many of the CEOs of pharma companies, and they ask you, what's the next molecule we should be thinking about? Yeah, that's the kind of conversation we have. So we've got a meeting with the company tomorrow. And last year I met with 2 CEOs of the companies, and I said, not to make any more new molecules. Said we have enough molecules, we have good molecules, we have really, really good drugs. What we're not doing is putting them into practice early enough. We're not starting them early enough. So I think that over the next few years, all of us as a healthcare community and researchers need to get more studies done. How can we overcome clinical inertia? Because drug trials are easy to do. Randomized controlled drug trials are very easy to do. Give either a comparative drug or a placebo drug. This is behavior change, both at the healthcare professional level and the patient level. And behavior change is very, very difficult. And it's not a simple randomized controlled trial, A versus B. This is where you need a whole system change. You need tools for the patients, tools for the professionals. And because it's complex and because it might not make the pharma that much money, people don't invest as much into it.
Yeah.
Please, may I react? Yes. Because, yes, many people with type 1 feel really abandoned by their diabetes nurse and are disappointed by being placed into a structure and being placed into a schedule of treatment. And I have the question, how many patients with diabetes, it's our hobby to be involved into diabetes, but when you're a patient, it's not really your hobby. How many patients are waiting for another appointment with another discipline and another professional who has another schedule? So this is actually one of the questions which motivated me a few years ago to go into children camps, to go talking with parents with a child with diabetes, to initiate a toddler center and deliver toddlers who are trained for babysitting and how to say, with children with diabetes in families who are disrupted by this serious disease. And the goal setting of patients with diabetes is having a good life. And ending up without complications is a medical goal setting. And when you say, well, you should be aware of this and this and this threaten, this is not very motivating. But when you ask, what is the problem you have in daily life? That's motivating. That's solving an actuality. And I think this can increase patients' adherence, so to say, enormously. But I'm not a scientist.
Can I just also make a comment on what we were saying? I think that times are changing for now for this new drug development. Because even now the pharma companies, if they want to sell the new drugs with the highest price they want, they also have to provide services, and they are trying to sell education programs, because with that they can put an added value on the drug. And so probably now it's the moment for us, for people interested in education, to approach them, because we have to be sure that what they are selling, it's the correct educational programs, the ones with quality assurance and every step taken into consideration. Because it's, as in technologies, we are always seeing now a lot of different apps on diabetes. And probably there are governments trying to spend a lot of money on that, better than just on education. And they don't have the slightest idea if that's working or not. And so probably it's our fault. We should try to convince those governments, should try to convince those pharma companies, because they are interested on that, and to try to demonstrate, go back to those values that we have been showing for the last 15, 20 years on education, and trying that they still apply, the strategy is there, the knowledge is there, the results are there, so we should just move together and with the new drugs, because for sure there will be new drugs, and so it's just a question of doing that partnership and trying to have the best of the two worlds on this. I think that's my view here.
Thank you, Philip.